Yeah, welcome to this week's webinar session. This will be the last session for the semester. And today we're ending off with the crossfire debate, where we'll be discussing management of an asymptomatic less than 10 millimeter lower pole calyceal stone. And Dr. Cleve Opel will be arguing for surveillance of the stone. And Dr. Naidu will be arguing for active management. Thank you. I don't think he uses so we make this Does this thing click? Anything wrong? Eh? I don't know all this thing. Can they hear me? All right, let me share my screen quickly. Apologies, guys. No, I can't edit, so it's a lot of the same thing, just with a different. How do we get back into ours? There we go. All right, can everybody see my slides? I'm going to start from the beginning. All right, how do I close this? Okay, it's got that reader view on. Good morning, everybody. Thank you, Sam, for the introduction. That's the last webinar of the first semester. My name is Cleve Opel. Everybody, if there's any issues hearing me, please let me know. And today I'm going to be arguing for the case of observation for an asymptomatic lower pole renal stone. So I'll jump straight into it. The prevalence of asymptomatic kidney stones is increasing quite substantially over the last few years. A study in 2008 in the US showed that on patients undergoing routine CT colonoscopy, about 7.8% were found to have asymptomatic kidney stones out of 5,000. They further extrapolated that and found that in 23 million CT abdomen that's performed annually in the US, 1.8 million stones were picked up. Across the Atlantic, this data is also sort of mimicked. The study in 2013 from Iceland showed that from 1985 to sort of current day, present day, the incidence of stones are increasing, and that's again been attributed to the rise or increased use of conventional imaging more routinely in practice while we're picking up these stones. So if you look at all the data together, looking at all the different studies, the sort of prevalence and incidence of asymptomatic renal stones is anywhere between 8 to 46%, which leaves with the natural history of what happens with these stones still unclear. It leaves us with the question, who should be treated and how should they be treated? Looking at the guidelines, EAU as well as the AUA sort of sits on the fence. They haven't given a solid sort of answer. In the past, they were more advocating for observation. Now they're back on the fence. They do have guidelines if you are observing someone that there are certain indications to intervene. So if the patient becomes sort of symptomatic, having obstructions, but they don't flat out say for such a size stone of this composition at this position, surveil or not. So
Hi, Cleve, I don't know if you can hear me. Cleve, can you hear me?
Yeah, we can hear you, Prof.
Sorry, the slides are not moving, and I don't know if you can maximize the slide as well.
Okay, from our side they are. Let me see if I can change anything here. Can someone just go online? Maybe we just make sure we are. How do we close this thing here? Let's just do it with the screen. Is that better, Prof, or is it still the same? issue. Okay. Wait.
Well,
So can we close the reader view? This over the next slide thing. How do we close this window? Can you show us?
Everything's in the way. It looks like this, huh? This thing's in the way, so it's probably about more. Video clip, hide video panels.
So just click a show taskbar
And that's a taskbar.
and you can't move this thing away.
Oh, let's try to share the PowerPoint instead of the screen.
So let's stop sharing.
Yeah. It's like that's recording.
Wouldn't it be that? Yeah. And then it should be able to share from there.
So
Did you see? I think it's coming. Yeah. Maybe it's just slow.
Current slide.
But it should be doing. Oh yeah. Sorry. Yeah. It's a... Yeah. I mean, it's all the same. Takes you there.
Apologies, everybody. We've got our best technical brains on the case here.
Sorry, I'm just going to pick us my head. Just to see that all the way to it.
And that's not from current slide.
Okay.
See if you can just move this top
There is a way I might present the view. Let's just click that up.
Please. You guys are sharing the main computer. You must either share the projector or change your screen settings to duplicate screens. Otherwise, you're going to get basically your presentation mode showing to us the whole time.
All right. So we need to do.
Okay. Go to your desktop.
Okay. Do what he says. Yeah.
Right click, go to screen settings,
Yeah.
and there should be a setting that you can select if you have dual monitors to duplicate them.
I think we found that. Multiple
Can you
display.
select the duplicate one?
Only one. All right. That's
And-
probably better.
And then try to run the slideshow now and see how it pops up.
And from again.
It's all stop sharing.
Stop share, yeah.
And then
Yeah.
would it be here or would it be?
Yeah. From beginning or from current slide. All right. Is that better? Thank you, Theodore.
No problem.
Thanks. All right. So as we, sorry for that interruption, guys. So as we said, with regards to asymptomatic lobe stones in general, the guidelines are still sitting on the fence. And the question which has been coming up quite frequently, and the question of this debate as well, is whether or not to treat these stones. So Streep and colleagues in 2018 also looked at this sort of question, and they divided factors which need to be considered before treating a stone into patient factors, anatomical factors, and stone-related factors. Looking at patient factors, they said that you should consider prophylactic intervention in asymptomatic patients who are unable to follow up or present to a casualty. Certain occupations should also sort of be treated prophylactically, such as pilots. We mute our things, please. Pilots, long-haul truck drivers, etc. In pregnant ladies, they say that if a stone is asymptomatic, you should not perform a ESWL or PCNL. These are obviously both contraindicated, as well as the GA being a risk to both the mom and the baby. One unique sort of cohort of patients is pediatric patients and what to do with asymptomatic low pulse stones in these patients. Telly and colleagues in 2017 performed one of the first sort of reviews looking at 242 children with asymptomatic low pulse stones, less than 10 millimeters. And they found that predictors for the need for future surgical intervention were a stone larger than 7 millimeters, a child with renal anomalies, and obviously stone composition, especially struvite infective stones. So those are the patient factors. If you look at the anatomical factors, which probably need consideration, a patient with a solitary kidney, because any obstruction which can result from spontaneous passage of that stone can lead to renal failure. And then they feel quite strongly that asymptomatic calyceal diverticular stones do not warrant any surgical intervention. So we've covered patient factors which need to be considered, anatomical factors, but the jury's still out on which stone factors or features need to be considered, and especially the size and location. Any obstruction needs to be considered. And then we obviously know stones, if this is obviously with asymptomatic incidental found stones, so we don't have a composition, but if you know a stone is infective, it needs to be treated. So with this being said, our treatment options obviously include observation, medical treatment, shockwave therapy, URS, and PCNL. But all of these modalities carry quite significant risks and side effects. There are multiple medical options available for treating a stone. We often use citrate. If you were to give a patient mispot sit, it can cause hyperkalemia if they're a known chronic kidney failure patient or a diabetic. Citrus soda is the other option, but that can lead to oxalate stones from a high sodium load as well as hypertension. Thiazide diuretics commonly used, but can cause hypokalemia and intracellular acidosis, if causing hypositraturia, which is again a risk factor for stones. If orthophosphate is given for anybody except for sort of absorptive hypocalciuria type 3, the phosphate leak type, you can get calcium phosphate stones. Allopurinol in excess can cause xanthinuria and xanthine stones. Your thiols have multiple systemic side effects, as noted in this diagram here. And then your medical management of infectious stones, including acetohydroxamic acid and hemiacidin irrigation, can both cause complications, both from the medication itself and if given with active infection. The side effects of Eswell, we can divide them into 3. Those related to the stones, they can get Stanislaus or renal colic. Those related to infection, they can get bacteriuria and sepsis. And those related to tissue complications, Eswell can cause renal hematoma, cardiac arrhythmias, bowel perf, liver, spleen hematomas, and skin ecchymosis and pain. We know URS can cause a perforation, long-term stricture, quite catastrophic, but avulsion of the ureter. The stone can become submucosal, even lost. And then UTI or sepsis. And then PCNL has obviously got quite significant complications. Hemorrhage, needing a blood transfusion in about 7%. Quarter of the patients end up having sepsis post-op. Can cause iatrogenic injuries to adjacent organs. You can have metabolic derangement from obviously our irrigation fluid. Injuries to the collecting system. You can get an embolization, neuromuscular palsy, or even death in 0.05%. So with this being said, on all these side effects, what if we told you that you can actually just observe these asymptomatic low pulse stones with avoiding all of these complications? There's quite significant data in support of this. One of the first studies, Keeley and colleagues in 2001, British Journal of Urology, looked at whether or not performing a prophylactic Eswell was a justified treatment option for these asymptomatic stones. About 228 patients up to 15 millimeter stone were randomized to observation of Eswell, and they found that there was no evidence of difference in the symptoms, quality of life in these patients, or renal functional tests between the 2 arms of the trial. Kang and colleagues also looked at just without intervention, pure observation of patients over an average of 31 months, 201 males, 146 females. 30% spontaneous passage, 50% had stone-related events, but only 4.6 of these patients needed surgery. They didn't specify, again, location of these stones. And interesting enough, they found male gender to be an independent predictor of stone-related events. So they concluded that an asymptomatic renal stone can be followed up safely, but long-term follow-up is necessary. Summary of all the evidence here, other than Hubner et al. Study in the 1990s, most studies show that the intervention rate for observation of asymptomatic stones is below 25%, with some as low as 7%. That's a bit of a delay. So with this being said, and what do we need to consider when surveilling these patients with asymptomatic low pulse stones? So the three main things are: what is the risk of this patient developing symptoms? What is the risk of this patient presenting to the emergency department for admission? What is the risk of need for intervention? And as well as the spontaneous passage rate and stone growth, but those aren't as important. So Durrad et al., when looking at symptoms, had a case series of 238 patients, average size, what we're looking at 10 millimeters, and only 15% of their patients had pain. They concluded that there was no difference in symptomatic events between those with a stone less than 10 millimeters or more. Dropkin and colleagues found that the only significant predictor of symptom development is the location of the stone. And again, there was no difference between stones under 10 millimeters and above 10 millimeters. They concluded that upper pole and mid-zone stones were more likely to become symptomatic as opposed to low pole stones. Again, Catherine Lovegrove and her colleagues, they performed a meta-analysis of the risk of symptoms, and they found that there was no difference in risk of symptoms when comparing stones under 5 millimeters to above 5 millimeters, or stones less than 10 millimeters and more than 10 millimeters. The next factor to consider is the risk of emergency admission. So there's only about 2 studies which looked at patients on active surveillance and who needed an emergency admission. And you can see there that in both studies, overall, less than 20% of these patients would eventually present. Again, these were patients being surveilled with not purely low pulse stones. Some of them had mid-zone, upper pole, renal pelvis stones as well. So still promising data. And then risk of intervention. So Lovegrove's article in the BGAUI looked at 9 studies which looked at who would need intervention for an asymptomatic stone or residual fragment smaller than 10 millimeters after previous surgery. If you look at the data here, especially Pulo et al. Study, funnily enough, they found that if a stone was larger than 10 millimeters, there was a lower risk of intervention compared to stones slightly below that, which is a bit bizarre. Berger et al. Found that for stones larger than 5 millimeters in the low pole, 20% risk of intervention. And if Coe et al. Found that, again, for stones between 5 to 10 and above 10, the risk of intervention was still quite low at about 15%. So this meta-analysis showed that there's a significantly decreased likelihood of a patient needing intervention if they had a stone 10 millimeters or less, as opposed to more than 10 millimeters. Other factors which we said we'd consider is spontaneous passage and stone growth. So smaller stones are more likely to pass spontaneously, as you can imagine. A stone in the lower pole is not going to pass spontaneously, but only 25% at most are likely to become symptomatic and need intervention in the short to immediate term follow-up. That's sort of the general consensus from most studies. Kane et al. Study showed that the risk of intervention or spontaneous stone passage was unchanged regardless of stone size, but in this study they didn't specify the location of all of these stones. And then stone growth. Sort of, if we look at all the studies in general, the rate of stone growth or the amount of stone growth in the studies reported between 5 to 33%. Lee et al. Found that stones grew about 5 millimeters in 16% of their participants, and that the size of the stone at starting observation was not a sort of significant predictor in predicting who would actually grow. There was no difference between stones less than 5 and those more than 5 millimeters. They also concluded that risk factors for stone growth were diabetics, hyperuricemia, and stones which were not in the lower pole. So lower pole stones were less likely to grow over time. So what does the data say from the observation and intervention trials? We've already commented on the Keeley study, which showed that Eswell doesn't seem to be justified for an asymptomatic renal stone. The study by Sen et al. Looked at 150 patients, followed up over 21 months, and they 2 arms, 1 intervention receiving URS and Eswell, and 1 observation. And these were, again, lower pole stones less than 1 centimeter. They found that the stone-free rates for intervention were quite good, 92 and 90% for URS and Eswell. The observation group had 12% rate of stone progression over a 2-year total, but the intervention group had all the complications up to a 12% complication rate. Uric et al. Further sort of expanded the study, looked at slightly larger stones up to a 2 centimeter burden. Instead of URS, they looked at PCNL. They found that the rate of intervention observation group here was 19%, but there was no adverse outcomes while delaying treatment. And that all, in their study, all patients underwent a post sort of observation or intervention DMSA scan, and they found to look for scars. And obviously in the intervention group, there was quite significant scarring after surgery for asymptomatic stone, whereas in the observation group, no scars. So I will conclude there for a bit, and then we will continue just now. Thank you. Should I stop sharing? Yep.
Yeah, thanks a lot, Dr. Oppel, for such a compelling argument for surveillance of patients with lower pole stones. We're going to move over to Dr. Naidu from Wits University, who will be presenting and arguing for active management of patients with lower pole calyceal stones. Dr. Naidu. You can just start sharing. Yes, thank you. Yeah, we can see your slides.
Can you guys all hear me?
Yeah, if you can just go to maximize slideshow. Yeah, thank you.
So is this full or is this still on presenter view? Can you guys see my full screen?
So it's not on full screen. It's on presenter view. If you can just change it for
Okay.
us.
All right.
Yeah, that's good. Thanks.
Okay, hi everyone. I'm Dr. Naidu from Wits University. So I'll be presenting on asymptomatic less than 10 millimeter lower pole calyceal calculi, and essentially arguing for active management and obviously your treatment options. Okay, so just introducing it. So, I mean, quite a lot of the stuff has been said in the previous presentation, basically about the type of factors and stuff. But essentially, the increased use of CT studying basically has made incidental detection of asymptomatic stones quite common, essentially with an estimated occurrence of around 8% of population which has been affected. So despite basically the frequency of the average asymptomatic stone, the size is only 3 millimeters, and frequency is generally located in the lower pole. Okay, so essentially either to treat versus not treating. So I mean, we've obviously in the previous presentation argued quite comprehensively on not to treat. So essentially treatment or non-treatment essentially favoring treatment is the theoretical benefit of preventing a future asymptomatic stone event. However, against treatment is the potential for morbidity, which is related to any treatment intervention modalities in the setting of which a stone may never actually become asymptomatic, of which we've obviously previously mentioned the rates of stones becoming symptomatic. Okay, so the asymptomatic lower pole stones. So certain studies show, essentially they suggest that the natural history of asymptomatic lower pole renal stones really require intervention. However, they do have a slightly higher rate of symptomatic events and growth over the intermediate term. So asymptomatic renal calculi, if untreated, renal stones certainly have the capability to increase in size and eventually lead to symptomatic events. Therefore, periodic surveillance is required with attention to specific risk factors such as age, gender, and stone history, essentially mentioned previously as well, which may suggest early progression and the need for closer follow-up. Essentially, in our setting, quite a few of these risk factors, as well as consistent follow-up, generally isn't well followed in our resource centers. Okay, so just mentioning basically on uteroscopy versus as versus active surveillance. A recent study by Senna et al., which randomized patients with asymptomatic lower pole stones, which were less than 1 centimeter, to uteroscopy as well as observation. essentially in the treatment groups, the stone-free rates following URS as well were excellent. So 90% versus 92% in URS and as well. So in the observational group, only 12% of patients became symptomatic, which was defined as pain, obstruction, or infection. However, the same group, the same rate of complications observed in the treatment group was the same as the patients that became symptomatic. Essentially, in the study, they found that the complication rate was exactly the same as patients that became symptomatic in observational group. So something I guess haven't really discussed, so essentially active surveillance in developing countries. So certain problems may arise when active surveillance, when you active surveil a patient for potentially non-lethal disease, essentially such as our non-symptomatic less than 10 millimeter lower pole stones. Essentially, when active surveillance is to be implemented in a developing country, we all know that in certain regions, access to a more specialized medicine is limited. For example, centers where you have urological resources or urology department. Okay, so essentially in rural areas, it's quite difficult for transportation or absence of proper medical services. Essentially, performing an appropriate follow-up requires at least an ultrasound personnel with experience or expertise in the field, as well as basic lab analysis. So obviously analyzing your blood test, 24-hour urine, which you may have done as well, and obviously access to be able to possibly CT the scan if need be. Okay, these are all not easily available worldwide, especially in our setting. Essentially, stone disease is not considered a priority currently in our system here, where we have a high trauma burden as well as high HIV and TB burden as well. Yeah, essentially, if you're needing someone who needs relatively close follow-up, either 6 months to a year, basically it's possible to do this in more developed countries, active surveillance. So certain complications. So essentially in about 2% of the cases of these patients with asymptomatic lower pole stones less than 10 millimeters, about 2% of cases, they found silent hydronephrosis, which obviously was not picked up if you hadn't done an ultrasound or your CT scan that was done on these patients, as well as surgical treatment was required. So basically, we can imagine that without proper follow-up, some kidneys can be lost if certain patients obviously aren't able to follow up appropriately at our centers due to multiple factors. Some of these complications can occur, which I think is quite morbid, essentially losing a kidney just due to something that had been asymptomatic. So additionally, a majority of the articles state that progression is generally linked to the size of the stone, which was also mentioned before. And essentially, we're not exactly sure if stones smaller than 5 millimeters have better outcomes than those with 5 to 10 millimeters. This is purely just based on if a 5 millimeter stone passes, it has a more likely chance of passing as compared to a 5 to 10 millimeter stone, where the 5 to 10 millimeter stone may not actually, be able to go into the ureter at that point. So essentially, spontaneous passage rates, as mentioned, are higher for less than 5 millimeter stones. So certain factors to consider. So essentially, we have mentioned some of these as well. So patients with solitary kidneys, certain immunocompromised patients, so either HIV positive patients, type 2 diabetic patients, patients on chemotherapy, renal patients, of which in our departments, we have quite a lot of these type of patients. Certain professional categories. So these type of patients will be air pilots, people traveling frequently to remote areas, or women who are intending to get pregnant soon. So these type of patients if they're intending to get pregnant soon, you wouldn't want them to have any symptomatic events while pregnant, as mentioned before as well, as well as contraindicated, as well as if you want to plan and do a URS, you wouldn't be able to do a general anesthesia. So these type of patients, you probably would want to get them stone-free before certain types of things, like obviously patients who want to become pregnant. Okay, so basically, is active surveillance a good alternative if the following criteria are met? So basically, following patients regularly with a small asymptomatic lower pole stone is a good alternative. If three basic conditions are not met, obviously it may be a bit difficult, but if your patient is motivated to do it, we would say it obviously is a good approach. If you have good technical, if there's basically a good technical condition to do it properly, which means you'll need to perform at least the sonar and the clinical evaluation every 6 months to once a year. So basically, obviously being able to surveil your patient every time they come to your clinic. And if your patient is not included in one of the groups that I mentioned above, or have any other particular medical condition. Otherwise, removing the stone may be the best alternative. So again, either treat or versus observe the patient. So basically, in a hypothetical situation, patients are giving basically a hypothetical situation of asymptomatic 8 mm lower pole stone and descriptions for observation. So essentially either annual radiography or 40% chance of growing of the stone growing more than 10 mm within 4 years, or 20% chance of passage. So essentially with as well 65% or with an as well 65% of the success rate, or with a ureteroscopy and laser a 90% success rate with a stent placement for 1 week. So patients who had an experienced greater pain or passed longer, larger or more stones, or passed stones more recently, had opted for definitive treatment. So essentially, patients who had previously had stones generally had and had been managed conservatively had opted rather for definitive treatment as opposed to active surveillance. So 22.6% of patients chose observation, whereas 29.7% chose ureteroscopy and 47.5% chose as well. So apart from obviously, lowish rates of patients developing symptoms or requiring intervention from active surveillance, one might also have to think about patients' comfort as well as pain thresholds with regard to this. So certain treatment factors and options. So with lower pole stones, essentially we always have to describe anatomy of the collecting system. So essentially this is due to the anatomy can influence the treatment outcomes for kidney stones. So Sampao and Araggio in 1992 described the lower pole spatial calyceal anatomy, which used in the cast, and suggested that some anatomical features could impact fragment clearance. So essentially show that the angle between the calyx where the stone is located and the renal pelvis, which is the infundibulopelvic angle, influence the stone elimination. So in a study published in 1997, authors described that a technique to measure the infundibulopelvic angle essentially influence stone elimination. Yeah. So essentially, the first line, which is line 1, links the central axis of the superior ureter with the central axis of the ureteropelvic junction. And the second line, which is line 2, follows the orientation of the main infundibulum in the lower calyx where the stone is located. Okay, so among 146 endocasts, among 146 endocasts obtained from 73 adult cadavers, 74 presented with an obtuse infundibulopelvic angle in the lower pole. 60.3% had lower pole infundibular with diameters more than 4 millimeters, and 56.8% of the lower pole strained multiple calyces. So infundibulopelvic angle is measured between line 1 and 2, as mentioned before. So in another study with 74 patients submitted for ESWL, for lower pole stones, 52 presented an infundibulopelvic angle more than 90 degrees, which is obtuse, and 75% of them had eliminated the fragment. Essentially, just gathering from these studies, patients who had an obtuse infundibulopelvic angle more than 90 degrees had quite a high passage rate of any stone fragments, whereas patients who had a more acute infundibulopelvic angle essentially had less chance of passage of any fragments. Okay, hold on. So essentially narrow infundibular, which is considered to be less than 4 millimeters, or patients who have complex lower pole calyceal anatomy are also related to lower stone free rates post any procedures. So yeah, so just mentioning a few of the treatment options available. So there's ESWL, which is electrocorporeal shockwave lithotripsy. So essentially, it's a non-invasive method of stone treatment introduced in 1980. Success of ESWL is quite highly affected by either stone burden. The likelihood of success decreases for stones more than 20 millimeters, or mentioned as well before, stone compositions, either pristine or very soft stones, such as struvite stones, essentially with a high amount of organic matrix. When the stone composition is unknown, stone density, which is measured by Hounsfield unit, can predict stone fragility and response to as well. So there was another study done, essentially looking at stone free rate. So patients with Hounsfield units of less than 500, either 500 to 1,000 Hounsfield units and more than 1,000 Hounsfield units. Essentially, noted there was 100% stone free rate of patients with Hounsfield less than 500, 87.5% stone free rate of patients with stones either between 500 to 1,000 Hounsfield, and basically 54.5% stone free rate of patients with quite solid stones more than 1,000 Hounsfield. Essentially, stone free rates also depend on the density of your stone. So essentially, the stone location is also quite challenging. So low pole stones are generally challenging to as well. This essentially, as mentioned before, Samples criteria. So patients are less likely to drain or basically able to expel those stone fragments based on those infundibular pelvic angle, infundibular length, as well as infundibular diameter. Okay, so obese patients also challenge for as well. So there are weight limitations on the lithotripsy table. Positioning of patients with high BMI is quite difficult, as well as excess adipose tissue dampens the energy that's being conducted from the machine. Okay, flexible ureteroscopy, rhinoscopy. So this is URS and laser. So essentially, uteroscopy is a minimally invasive method. They have high success rates and low incidence of complications. They're generally not affected by obesity and can be performed ovulated patients, which is a contraindication for your as well patients, or during pregnancy, which is also contraindication for your as well patients. Can either be done via general or spinal anesthesia, as well as either outpatient or in short hospitalization stays. So essentially major drawbacks are the cost. So quite a few disposables that are needed. So your laser fibers, if you obviously have disposable flexible uteroscopes, your guide wires. Another option generally percutaneous lithotomy. So essentially quite a efficient method in terms of getting patients stone free. However, has the highest morbidity amongst other methods. So we did mention certain complications in the previous presentation. However, there have been some changes essentially with PCNL. So essentially, there's been mini perc, which is to 18 or 20 French track, so ultra mini perc, which is 11 to 14 French, or micro perc, which is less than 10 French. So generally, the more miniaturized PCNLs are for stones less than 30 millimeters, which I mean, not really talking about in this presentation. But essentially, there was another study with a comparison between mini perc and uteroscopy for lower pole stones less than 15 millimeters. So essentially, that showed 91% stone-free rates in both the methods, essentially with a shorter operative time, but longer hospital stay for mini perc as compared to uteroscopy as well, and laser. These are just some of my references that I use. Okay, thank you. I think we'll go back to any questions maybe.
Yeah, thanks a lot, Dr. Naidu, for your argument for treating these patients with asymptomatic lower pole stones. I think we'll just quickly address the questions on the charts before we move over to rebuttal. Cleve, if you can just address the question from, it's going to go up, yeah. Yeah.
Thanks, Bernard, for that question. Yeah, so in that study, I was also found that quite strange. That's why I sort of circled that. I think of all the 9 studies looking at the rates of intervention, that was the only study which showed for some reason that stones 10 millimeters and greater had a lower intervention rate, 20% versus slightly smaller. So, I mean, it's 1 out of the 9 studies. It's an isolated event. All other studies were sort of in keeping with what you'd expect. So they didn't have any sort of explanation for their findings there. Yeah.
Well, just go to that. Sorry, because you can just go to the other question that we have there for Dr. Naidu. I don't know if you can see on the charts. Yeah, I mean, Cleve, I haven't had a look at your study, but I'm just wondering if it's probably not because these stones are more likely to migrate because they're smaller. If there's a narrow infundibule, so and then maybe they're not able to migrate much, but probably not scientific. Dr. Naidu, do you mind just addressing the question that was posed to you? Quoting that SINA study.
Yes, I'm just reading it now.
Okay, cool. Are you still there? Dr. Naidu, are you still there? We can't hear anything. Your mic is muted.
Sorry, yes, yes, I was muted. Yeah, so essentially, on the SINA study that I mentioned, so the number of procedures and average length of procedures to achieve stone clearance. So essentially, I hadn't actually checked the number of procedures, but the average length of the procedures were quite high as compared to the PCNL group. However, the number of procedures, it was basically determined on the stone size, which essentially patients may have needed multiple or more than one procedure to achieve stone clearance. But essentially they compared, essentially one procedure versus a PCNL group to see if they had what the percentage of stone clearance was as compared to that.
Thanks a lot for that response. We'll just move over to the rebuttal. Cliff?
Chaps. Where's my presentation? Should I open it again? Yeah. Or you can just share the screen and then open it from here. Okay. And that should work, right? Everybody hear me? We're just going to do a quick rebuttal there. So two things I want to highlight are the expenses behind treating an asymptomatic renal stone and the complications. We started this talk by mentioning that the prevalence was sort of climbing every year, and in the US sort of annually 1.8 million asymptomatic renal calculi picked up. Data from, I think this is 2021 in New York City, showed that this is the average cost of treatment for each of these interventions for renal stones. URS $3,000 to $12,000, as well $7,000, PCNL $12,000 per sort of intervention. So we said 1.8 million stones. So I mean, you're looking at cost of billions of dollars to treat something which is not troubling the patient, unlikely to trouble the patient, unlikely to cause any issues in the future. In a country with limited sort of resources like ourselves, I mean, it's a sort of no-brainer. We can't be treating all these asymptomatic renal stones. Added to that are the complications with intervening with these stones. We mentioned all the morbidity and toxicity which comes with all interventions from medical to sort of invasive. We have both agreed on that there are certain factors which you need to consider before treating a stone, certain patient factors, pediatric, the solitary kidney. But even then, you don't need to perform those sort of procedures. There's a sort of something that I saw, I don't know if I don't think it's being practiced routinely. The studies from 2001, it's a new sort of novel technique called burst wave lithotripsy. Basically, it uses ultrasound and looks they've basically found that this technology provides consistent, effective lithotripsy of stones with minimum side effects and tissue damage. And that the same ultrasound probe which provides these burst waves is also then used to propel the fragments into a position where they will pass spontaneously. So if you look at ISWL versus burst wave, we know ISWL, there's multiple ways in how it works, but essentially if you're going to break it down to sort of fine fact, it's going to be causing sort of fragmentation of the stone, which is similar to fragmentation setting when you're doing a laser. In contrast, burst wave sheds of small pieces of the stone from a large stone, and it's equivalent of dusting when performing laser lithotripsy. And this is achieved by using focused sinusoidal bursts of ultrasounds with repetitive stress in multiple regions of the stone. So this study is, as I mentioned, novel intervention by this university. I think it's in Massachusetts in the USA. It's an ultrasound probe with a water coupling device, ultrasonic propulsion probe, and performed obviously under real-time ultrasound. So you can actually see where your stone is and get an idea of what your fragments are looking like. They had two patients, one with a lower pole stone, like our debate today, 7 millimeter stone with a skin to stone resistance of 7 centimeters, and a distal ureteric stone. And with the lower pole stone, after 9 minutes of this burst wave lithotripsy, they were that 7 millimeter stone was fragmented. As it was a novel technique, the patient had to be under GA for this, but they were able to, they performed a URS and found all fragments less than 2 millimeters after fragmentation. And then using that same propulsion from the ultrasonic probe, they were able to position these very small fragments into a position where they would pass spontaneously. So they concluded that birthway, also for the ureteric stone, which isn't the topic of a discussion, that patient was done awake in the rooms and was able to pass the stone sort of spontaneously at the same setting. So they concluded that this it's a non-invasive method, which is quite shown promise to treat sort of these lower pole stones if you do indeed need to treat them. So in summary from my talk, we know the prevalence is increasing due to the increased use of conventional imaging. Outcomes of these lower pole stones include a symptomatic event, spontaneous passage, size increase, and need for intervention, less than a quarter of the cases. We know as well does not improve stone-free rates or quality of life compared to observation, and that immediate treatment in the form of URS-PSNL does not demonstrate improved outcomes. Also has a higher risk of complications, which may be worse for the patient than any benefit, as well as a quite significant expense. Guidelines are still on the fence, and the optimum sort of follow-up modality and frequency of follow-up for untreated stones is still not yet been established. Thanks.
Right, thanks. We'll move over to Dr. Naidu for any rebuttal.
Hi, Prof. From my side, there wasn't anything else.
Sorry, Dr. Naidu, I didn't hear that.
Sorry, Prof. From my side, there wasn't anything else.
Okay. Are there any questions from anyone else or any comments? Cliff, I'm just going to ask you a question quickly while we're just quickly setting up a poll. So I mean, in your institution, how do you approach patients with the low pole 10 millimeter asymptomatic stones?
Thanks for that question, Sam. Yeah, so these low pole stones, or these stones, asymptomatic stones, are quite obviously a heavy burden, especially in our setting, in the state setting. To such an extent, we actually have a dedicated stone OPD every Friday today to treat this exact problem. So I think in a patient, we mentioned there are certain factors you need to consider in an asymptomatic incidental low pole stone. Obviously, one kidney, patient unable to follow up, certain occupations. And then obviously with the stone itself, if a patient had a stone before, so it's no longer incidental, you've treated stones, you've got residual fragments, and you've got composition confirming a struvite stone or something like that, we know you need to go back and clear them. But in all other patients with an incidental asymptomatic stone is not having UTIs or as residual fragments under 10 millimeters, I think they can be safely observed. We do safely observe them in the sense that we do see these patients, we give them routine follow-up, we see them all with a plain film abdominal x-ray sort of every 6 months or so. So yeah, I think that has reduced the sort of theatre burden which would come with treating all of these stones.
I'll just address that, Cliff.
Just interested in the yes, so that 50% burden, when they talk about 50% stone-related events that occur in that patient, they were, it was things like sort of, not really renal colic. Some patients did obviously experience colic. There was a few sort of UTIs and that sort of thing. But when they talk about surgical intervention for those patients, they only of that 50%, 4% needed stuff like, you know, obviously PSNL, URS. So yeah, I haven't actually looked too far in that data. I just sort of noted that they spoke about 4% surgical intervention. But the stone-related events that are 50%, as far as I can remember from that study, it was just sort of intermittent dull flank pain, but it wasn't sort of severe colic needing anything sort of intervention. But I can go check on that study again. Apologies.
All right. Thanks a lot for that, Cliff. I just want to launch this.
Let's see.